I'm Rachel Horgan. Join me each episode as I sit down with a guest co-host covering the latest business stories in the Seattle area. We'll read the news so you don't have to. This is The Weekly. Welcome, everybody. My big update in preparing for this episode, I finally booked my gynecology appointment that I've been putting off. As many of you know, I didn't have insurance for a year and I was living on hopes and dreams. And I've been meaning to make this appointment now that I have insurance. And as I was doing this research, you'll realize why I finally did it. So yay for me. The other thing, speaking of women's health and health in general, I've partnered with Formidable. Many of you know Emily Parkhurst with Formidable. She's putting on a Women's Health Summit October 30th at the Maidenbauer Center. We are just working on kind of the reg page and all that kind of stuff, but I wanted to start putting it in people's ears. It's meant for your everyday person to come attend and learn all about women's health. It's going to be very, very cool. So I'll share more when more is announced. But without further ado, you probably can guess that this episode is going to be about healthcare because I'm sitting across from Dr. Elizabeth Wako, President and CEO of Swedish Health Services. Hello.
Hello, and I'm so glad you made your appointment.
Thank you. It took not a lot of time, and I don't know why I've been putting it off. It seemed really hard in my head.
It's psychological, but I always feel like as women, we put ourselves last, so I'm glad you put yourself first.
Thank you. Yes. I'm excited to go. Not excited, but I'm excited to get hopefully a clean bill of health. So a little bit about you, for those that don't know. Swedish Health Services is an affiliate of the Providence family. So you've probably seen that logo that says Providence Swedish. And it's the largest nonprofit health system serving the Seattle area. And just to give you kind of a sense of what Dr. Wako oversees, it's 1,500 licensed beds, 53,000 annual inpatients admissions a year, and roughly $3.9 billion in revenue. So she's overseeing quite a bit, and we're going to hear a little bit more about what her day-to-day looks like. Before this current role, she served in many key executive roles at Swedish, and she received her bachelor's at UW, local Seattle. Well, did you grow up here?
No, I grew up in the Midwest.
Okay, then you came out here for
I came out Walla Walla first, and then out to here to go to the UW.
Okay, and then you left us a little bit for Utah.
Yes, I did.
But then you came back. You remembered how great Seattle is and came back and to do your medical residency and to get your MBA.
Correct.
Did you do that at the same time?
No.
Okay. I was like,
residency
that sounds crazy.
first.
Yeah.
Had some children, then came back for...
Oh, okay. When studying for this, did you feel like you were back in school, like studying for an exam for all the
MBA?
All the articles I sent you?
Oh, this?
Yeah.
No.
Like you have one day to read all of these. Okay, so I want to know how and why did you get into the medical field?
Well, I think healthcare was probably inevitable. My mom was a nurse. My father was a professor. My mom's job sounded cooler and maybe more fun, and you got to care for people. And I don't know, she made it look really good. So I actually started out in nursing.
Okay.
And then became a physician and moved into becoming a physician because of my experiences in healthcare. And then also, I mean, once you get in a hospital and you work in a hospital,
you're hooked.
You're hooked. And you realize everything is achievable to you. So,
like what? What do you mean?
I think sometimes you think it would be incredibly difficult to become a nurse, or it'd be difficult to become a physician, or you put people on a pedestal. It seems like that would be really hard to achieve, or it would take smarts that maybe I don't have. But then when you meet the people and you see the work, you realize it's achievable.
Yeah. I feel that's sort of what I do with this podcast. Is I think a lot of people are like, I could never be a CEO. And then you start talking to people like, oh, no, like this is, people do this, right? So you kind of mentioned you went from the nursing role to practicing medicine. I think you had anesthesiology for a bit, right?
Yes.
Okay. And then now, obviously, you're in this leadership role. What was that shift like from practicing medicine to leadership? And was that something you knew you always wanted to do? Was that the end goal?
Definitely not the end goal.
Okay.
I think that for me, really, the end goal was to become a physician when I started. And then once I was practicing, I missed some of the things about nursing. So I practiced as a nurse for 5 years. And I was a leader as a nurse. And I think I missed some of that way of kind of engaging with our patients and engaging with my colleagues that I didn't have being an anesthesiologist. That's very one-on-one.
Right.
So I picked up some leadership roles and became a medical director for a pre-op clinic. So the work you do before the patient goes to the operating room. And so I kind of, I think, fulfilled that desire in that way. But I didn't think that I was going to end up becoming the CEO.
How did that happen? Just kind of one step after the other?
Literally, one step after the other. Once I became a medical director, I was asked to be the chief medical officer. And then once I became the chief medical officer, I think that's really where you see what the administrative world looks like. I had that view, and seeing that view made me realize that there are ways that you can affect patients' lives that are so much more than what I was doing taking care of a patient.
So you're kind of stepping back, bigger picture. Like, what if this entire process was different, this entire policy, or like the whatever? I'm sure you're making some of those bigger decisions.
It's a really hard decision to make. It happened slowly, and then one day I realized that I was going to have to stop practicing. Mm-hmm. That was really hard.
Yeah. Well, do you do it in your everyday life, though? I'm sure all your friends ask you.
Yeah. It's not the same. No, it's not the same. There's nothing like that connection that you have with a patient as their physician. And there's no other relationship that's comparable to that. I don't feel like I can possibly touch an individual in the same way. And that is what I really miss.
Yeah, I can't even imagine. I think it's so important, though, for somebody that's been on the front lines to be in this role, because you know how it all works. One more question before we get into our stories, which is you were the interim CEO for a little bit, right?
Correct.
I've always wondered what that's like. Is it like a tryout for a team where you're auditioning, or is it kind of like, oh yeah, we all know it's going to be me, we're going through the paperwork? You know what I mean? Like, how did that feel to being the interim?
Okay, so I was the chief exec before, meaning I ran all the hospitals before.
Okay.
So coming into the CEO role as an interim, it was different than I thought it would be, but it was always, it was part of the plan. But whether or not that happens, I mean, you never really know. I mean, there's things that have to happen before you move into the role. And even though you're on the bench, doesn't mean you ever get off the bench.
It's true.
So I was surprised, first of all, that I had the opportunity to be the interim, but I took the interim role like I was the CEO. Like there was no... Like I stepped in and I made decisions. I think sometimes people are interim and they're tentative or they're unsure, or if you come from outside the organization, you don't know what to touch. But I came in I knew exactly what I wanted to do, and I came in. I was like, "This is my chance."
If I only have this power for 3 months, you bet I'm using it.
I'm going to use it for those 3 months. So maybe that helped. There was a pretty clear process to hiring the CEO, so I had to go through an interview and everything, and I was very
Yeah. I think that's good advice, though, for people, that if you have an opportunity to be interim, whatever it is, act like you already have it.
Yeah.
See what you can do. All right, we're going to talk about kind of 3 different stories today. The first one isn't linked to a direct article. We're just going to dive really into the business of hospitals and healthcare and solve everything in about 5 minutes. And then we'll talk about Starbucks buying office space in Nashville. And lastly, we'll close out with some news about the Kraken being a majority owner of Climate Pledge Arena. All right. Dr. Wako, let's start with the business of hospitals. So we kind of talked about your position a little bit, but can you share more about what does your day look like as a CEO? What kinds of decisions are you making? Help people that are not in the healthcare industry understand what the role of a CEO of a hospital does.
Okay, so it's not exciting. It's meetings after meetings, after meetings. After meetings, and then a social event, and then maybe another meeting in the car on the way home. Yeah. So it's a lot of meetings, but different topics, right? So it's patient safety and quality is probably the biggest. And then, our caregivers and our physicians, a lot of operations, finances, strategy. And then there's the community work and advocacy. There's foundation work, and then obviously the tower, the Hughes Tower. So lots of decisions that's, taken up a fair amount of my time also. So lots of things. And it's variable, but, some days I can spend 12 hours focusing on one topic or dealing with one issue. And some days, I can focus on things like strategy or think about where do I think we're going to be 10 years from now, or where do I even think King County is going to be 10 years from now.
Yeah, and it's important to give yourself time to have those daydream moments or kind of think of those big pictures. So can you share how Providence Swedish is funded, whether that's federal, state? I was reading some articles that some funding is going away, both federally and the state level. But I know obviously there's donations. So yeah, I guess how is yours funded?
Okay, so we're funded pretty much like every other hospital is funded. So it's by our payers, meaning our patient population. So we have patients who come in, and then the patients have either commercial insurance or they have government insurance. So government insurance is Medicare or Medicaid is insured. And then there's some that are come in that are self-pay. So that is generally how our revenue comes in. You said philanthropy, which is true. It's a small amount, and we tend to use philanthropy for new and innovative design or projects, or to support research projects or things that the teams may be working on. But a majority of it is really the payers that the patients bring in. And so the challenge that you're hearing about healthcare is that healthcare is either a commercial payer or governmental payer, and the governmental payers pay less than the cost of care, and the commercial payers generally pay more than the cost of care. So
you're losing money on the government patients, and you're trying to make up for it on the other ones.
Yes. And the challenge is that standard has existed forever in healthcare, and what you're seeing with HR1 and the shifts in payments that we're receiving for patients is that as you receive less federal funds, where does that cost get covered? Because the patients don't really go away, but it just leaves a greater deficit. And so that's the challenge where you're hearing around healthcare, is because there was a very tentative balance, and now that balance has been shifted.
So is that explaining, I think when the everyday person goes into the hospital or to the doctor's office, it's an exorbitant cost. I mean, hundreds and thousands and all of that. And then at the same time, and I think both things can be true, we're also hearing hospitals and healthcare saying we're doing layoffs, we're struggling. And I think sometimes it can be hard to reconcile that of how could you possibly be struggling when my bill myself is like, $100,000. So do you think that the answer to explain that really lies in what you were saying, the difference of the government funding, or is it kind of more complicated with insurance companies? How can we rectify that in our heads?
So as a patient, what you're paying for care is you're not paying the full cost of care. What we're charging you actually doesn't cover everything. If you think about it, there have been a significant increase in labor costs, in supply costs, that we're seeing as an organization that really didn't settle post-COVID. In addition, our reimbursement has gone down. And when I say reimbursement, I mean kind of what the governmental payers are paying us, and even the commercial payers are paying us.
I've heard commercials not paying as much as they used to. Is that true, you think?
For sure, it's true. But it kind of comes out on the other end also. We'll submit for, so you'll come in and you'll have a colonoscopy, and we'll submit the claim for the colonoscopy, and then payers will either deny the claim or they'll delay payment on the claim. And so that will eventually affect kind of our bottom line, because then we spend time kind of dealing with those denials, and we might not get paid for 30, 60, 90 days, during which that time we still have to pay for our employees.
Right.
And our patients are much more complex than they have been historically. And so that also has increased the actual cost of care that we're delivering.
Can you say more about that?
So our Medicare population is increasing, and the Medicare, meaning our patients that are over the age of 65. And with that, you don't have the offset. So generally what we have is we have the patient population that's relatively healthy. They come in and they use a lot of resources, and they leave resources then for those that come in and are more complex. But if your kind of triangle shifts and it, flips, so now you have a large number of people who are coming in who are over the age of 65, therefore likely more complex care. And it's not being offset by those kind of younger who are just, seeking, they have a cold or maybe something easy that they're receiving care for. And then what's new that didn't exist historically is now you can go to other centers to have those taken care of, right? Like you can meet a doctor online. You can go to a minute shop at one of the drugstores. And so you're taking those kind of easy dollars out and leaving all of the, incredibly hard and challenging dollars with no offset on it.
Yeah, that's really interesting. I read an article that you said 10,000 baby boomers are signing up for Medicare every day. And maybe that stat has changed, but probably still around there. What is Swedish doing or trying to do to prepare for some of this shift in patients?
In patients? Well, okay, a lot of it is really focusing on primary care. We are still in a fee-for-service world, meaning we get paid for the service that we provide. And we really would like to move to a value-based component of care, meaning we pay or we receive compensation for a whole life for a year, right? And then you feel, as the deliverer of care, the responsibility to keep that patient healthy. And that's very different than coming in an emergency setting and then taking care of care. So if we're able to move to kind of a value-based care, which really means supporting primary care, setting up a network of social support, especially as we're looking at this Medicare population, then we'll be able to, I believe, use the dollars more reasonably instead of using them in high acute moments.
Are other hospitals doing things like that?
Yes, I think everybody's kind of looking towards that. You do have to have the payers aligned to that. And some structures we have are fundamentally have to change to be able to move to a value-based care, and everybody has to be kind of willing to participate in that.
Mm-hmm. Would this be like a subscription? Not subscription, that sounds awful, but like you pay monthly or you pay annually to have...
I mean, you do that anyway.
I guess you're right.
Yeah,
you're
but
right.
It's kind of... but there's also... you would kind of have to stay with the same provider, which is not something that we do very well. Think about it.
No, I don't have a primary, and I almost have never seen the same doctor twice.
Exactly. But that's because your insurance is part of your employment. And I think the tying of insurance to employment fundamentally creates that. And so if you are constantly changing who your insurance provider is, then your insurance provider is less willing to invest in you as a person, right? Like, why do I want to invest the dollars in keeping you healthy when it's cheaper to really pay for each incident of care that you need? Because you're not going to stay with me. I will invest all of this in you, and then next year you're going to switch to a new payer. And it could be because your job changed, or it could be because it's cheaper. But either way, you're not committed to that payer.
Yeah. I think going back to what you're saying about focusing on primary care, I was curious about that because from what I've heard, that's not where the money is. The money is on these elective surgeries and some of that. But I think you've explained it a little better of like, if we think of the whole picture, this could end up helping us get right size with money.
Correct. Yeah. And that's how I think we all need to start thinking about it.
Mm-hmm. I want to ask, I think one more on this. You'd mentioned about labor costs. I know during COVID, because I dated a travel nurse, that there is a significant increase in travel nurses, and we know that they are more expensive. And so what I thought was happening is kind of the nurses, regular nurses, were turning into travel nurses because they're like, well, I can make more money. Mm-hmm. Was that happening?
Yeah, that's what it was happening.
Like. Okay.
Yeah.
And then now I'm kind of wondering, we're past COVID. Do we still have this excess of travel nurses that are now expensive, or how is that kind of shaked out?
That was a supply demand, right? So we needed nurses. A lot of nurses were retiring. Like if you could have retired, you would have retired.
Like, get me out of here.
Yeah. Yes. Yeah. Or, a lot of nurses also are second wage earners in the family. So remember when all the kids are home from school, one person has to stay home.
Right.
So even if you were splitting it 50-50, automatically you're working less, right? So there was just a gap of where we needed nurses. And so during that time, there was an escalation in what we would pay for nursing. And so that escalation also pushed people out. Like, so if I'm just making a regular employed nursing salary and I could go make double and be an agency nurse, why wouldn't you go make double and be an agency? I mean, if you could and you had mobility and flexibility. So post-COVID, though, things have settled out, right? The kids have gone back to school. Everybody who's retired is kind of retired. We did, a big influx of new nursing students, and things really have just stabilized. And we're probably at our best around agency utilization. Like we only use agency when somebody goes on a maternity leave or...
Okay, so it's kind of level set.
It's completely level set. And the compensation has become reasonable. Like you should get something for traveling and working kind of outside of your area and your comfort zone, but not at the exorbitant rates that they were before.
Yeah. Unfortunately, I saw some headlines about having to do layoffs. And I think when I see a hospital doing layoffs, I believe that they did everything they possibly could. And this is the last resort. When I see tech companies do layoffs, I don't quite think the same thing. Was there anything that you wanted to share that maybe the headlines missed about that story, or anything that you wanted the general public to know more about?
I think you said it, and thank you for thinking that. I don't think that the general population appreciated how much work we did to not have layoffs. So all the operational changes, the efficiency, the workflows, really the programmatic evaluations, we did so much to actually not have to do layoffs. So I love that you saw that and that you shared your thought.
Yeah. Okay. All right, we're going to move on to our next story. We're still going to talk about healthcare, don't you worry. But I will update you on Starbucks. So Starbucks they signed a lease in Nashville for a space that can hold, based on the square footage, they can hold about 2,000 people, they think. But Starbucks has not confirmed how many employees would be going there. The lease runs up to 23 years, and it starts around $11 million a year. The company says, I think some people were starting to freak out, like, oh my God, is Starbucks going to move headquarters, et cetera. They say they have no plans to move headquarters, but this is the largest expansion outside of Seattle. So I think people are warranted to be concerned. One landlord is worried that Seattle employers are being incentivized to relocate, for example, Nashville, because Nashville is giving them a lot of tax breaks. I think we've talked about this in other episodes of just the kind of the tax situation for employers, and we might be seeing more leaving. Do you want to comment on anything of this, or I was going to ask you about the Hughes Tower if you're ready for that?
Yeah, I'm totally ready to talk about the Hughes Tower.
So speaking of new spaces and new buildings, I saw that you're building what's called the Hughes Tower. So what's your role in this, and tell us more about it.
Well, we're super excited about it. We've been, I think, working on this building for over 10 years, and really it's replacing aging infrastructure on our First Hill campus. So it is an amazing tower. It will replace our ORs, our operating rooms, and our emergency rooms, who are the oldest spaces that we have in the hospital right now. We needed to replace it because of age, and they were not seismically sound. So it was essential.
Oh, like if there was an
earthquake. If there's an earthquake, it was,
yeah. Okay.
Yeah, we want to make sure that if there's an earthquake, there's a place for you to receive healthcare.
Yes.
And then we also needed to think about how we're delivering care in the future. And we had two campuses, the Cherry Hill campus and the First Hill campus. And so this also allowed us to do a consolidation of the campuses. So I feel like it's a major investment in the Puget Sound, certainly a major investment here in Seattle, considering that Providence Swedish provides about 25% of the inpatient healthcare for King and Snohomish County. So it's a lot.
That is a lot.
We learned how essential we were during COVID. We took a lot of patients from Eastern Washington and really supported both the Puget Sound and Eastern Washington. I think it would have been very difficult to deliver care without us contributing to the system.
Absolutely.
So my role is to get this project done and over the line, obviously on budget and on time. The other thing is to safely move into the hospital, right? Because we're moving Cherry Hill over into First Hill.
Probably a lot of change management in that process.
Endless amounts of change management, lots of people involved, which I've loved. It's amazing to see the teams work. And, sometimes in healthcare, it feels like, we don't have anything to look forward to, especially, with all the cuts and the finances around it. The best thing about this tower is, I think, is it's given our caregivers hope and something to be excited about and something to anchor onto. So even though it is a ton of extra work for everybody involved, the excitement around it is truly palpable. Yeah. So we love it.
Is there anything, like any specific part of the tower that you're most excited about, that you like nerd out on, that there's like a really cool feature in a room, or, I don't know, a cool thing?
Cool thing. The operating rooms are pretty cool. I'm an anesthesiologist, so I spend a lot of time in the operating rooms.
But what about them?
The technology, the space, the innovation that we're going to be able to bring in. So that's pretty cool. And then I also like in the ICUs. Normally, you have an ICU room and a regular floor bed. And when you get discharged from the ICU, you get discharged into a different room. But we did acuity adaptable rooms, so rooms that can start out as an ICU and become a bed, so you don't have to move as a patient. So
that's nice.
That's kind of cool and fun. And there's going to be some pretty amazing technology in the room. So, it'll be amazing.
And when is it supposed to open? Allegedly,
October.
As we know, it's never.
Nothing's ever October. But I will say the fall of 2027.
Yes.
We're very excited.
One more on this is that, this article about Starbucks is kind of hinting at the relationship between the city and Starbucks. So I wanted to kind of know from you the relationship between the city, the for-profit business community, and the hospitals. What do you think needs to change, and what do you think is working well as you interact kind of with this business community?
Okay, so what works well is partnerships. And we have some really good partnerships that kind of improve resilience in the system, but really avoid duplication. So really kind of that specialization. The city's been really great in the businesses and the community organizations and health systems in our ability, I think, to partner with one another. We saw a lot of that during COVID. I mean, you would think that we would be competitive as different hospitals, but it turns out that really when it comes down to it, everybody does their thing and then we all lean in and really make sure to support one another. So that's what I really like about this community is we're willing to work across spaces that one would think were competitive to make sure that in the end our patients and our community receives the best share. So that I love. Okay, what needs to change? I don't know. We have some, pretty challenging policies. I think our tax policies have been really difficult. We think about our challenges with HR1 when really some of the policies that we've passed in certainly Seattle in our taxation and then at the state level have been more challenging for the short term really than HR1.
Can you explain HR1?
HR1 is the federal bill.
Oh.
That changes how Medicaid is managed in the different states. So that's kind of looming for us. We think kind of kicking in 27, 28. That's eligibility and enrollment that you've heard about Medicaid.
Got it.
Yeah. So that's been challenging.
Yeah.
Regulatory, governmental support, really.
Is that if you could change one policy today, tomorrow, magic wand, would it be something around that, or what would you change if you could?
One thing that I would change is really to move towards value-based healthcare at a more accelerated rate. I think really looking at the whole life, I think it will mean better care for us, but I also think it will reduce the cost of care.
Yeah, I'm all about the reduced cost of care. All right, Dr. Wako, we're going to move on to our last article. So this is about the Kraken. They are now, Seattle Kraken owner Samantha Holloway and the rest of the team's ownership launched a new parent company called One Roof Sports and Entertainment. And for those listening, you might recognize the term One Roof because we interviewed Mari Harita. She's the One Roof Foundation executive director. So that's kind of their nonprofit arm. So now they've created this new parent company called One Roof Sports and Entertainment. The Kraken CEO, Todd Lewicki, and his team is also going to lead this new organization. The company then took a majority stake in Climate Pledge Arena, and they took it over from a Denver-based developer. That Denver-based developer will still maintain some stake in the operation and operate the venue, but now that this One Roof has majority. And fun fact, just, you know how people say when you get a job, it's like all about who you know? In this article, it says that Todd Lewicki's brother is the co-founder of that developing group, Oakview Group. So I thought that was funny. And then the last thing is this is just coming off the heels of our last episode. We talked about the NBA expansion, and now Samantha Holloway is considered a front runner to maybe be the new owner. This is all gossip, obviously, but could be true.
And it'd be awesome if it was.
I know. Fun. Okay. Let's talk about sports. So Providence Swedish was on the front of the Sounders jersey, and I read an article that partnership is kind of coming to an end, but there's still more to it than just the jersey. So can you talk to us about the were you involved in the strategy of kind of ending that, or did that just contract end, or how did that separation
happen? The contract came to an end, but it was really around really focusing our resources on our core patient services. And so that really just made more sense. We still will definitely continue in the community work and our medical care relationship with the Sounders, but it was really how do we use our resources in a way that it's focused on patient care.
Yeah, and I read that there's still some, helping high school students with mental health. There's still parts of that partnership that you might continue. Was there any stat that you're most proud of in that partnership, or anything you want to share about it?
Okay, so my favorite one is that this partnership enabled mental health support services to be accessible to 15,000 students in the Renton School District at no cost.
Wow.
So pretty amazing. We were able to do virtual therapy and embed it into the school day and their home environment. So impressive, especially if you're thinking about mental health for our children post-COVID. The impact was very real. 75% of the students that participated showed a measurable clinical improvement, and 66% reported feeling more confident in managing their mental health.
We love to hear it. We love to hear it. Yeah, I think people don't realize, that partnership. Yes, your logo was on the jersey, but it's so much more than that. There were so many community programs I was reading about, so I wanted to make sure that got on the episode. At the helm of this deal that I just talked about is co-owner Samantha Holloway, one of the few women in leadership for men's hockey. You are the first woman and the first Black person to lead this organization since it's founded 116 years ago. So when I was doing some research, a lot of the headlines when you first got this role had that in the headline, and I just wanted to see how does that sit with you, knowing having that kind of moniker on those headlines.
Well, I understand why people notice it. I think that representation matters, and it kind of makes me sad that you have to notice it, that it is an abnormality, but I appreciate it. And I also realize that it makes a difference in other people. I think being able to look and see somebody who's achieved something that looks like you or is the same gender as you, I think that does make a difference. So I'm happy to carry the weight of that.
Mm-hmm. Yeah, I agree. I think it's obviously representation is important, and I like to see those headlines. And I don't know if it takes away, because some people might say, well, why don't they say, X professional who has X amount of years, now CEO, why are we saying this? And I don't know if it's an either or. I don't know if one takes away from the other, but I was curious how you felt about it since it was about you.
Oh, that's very real. It's funny, what makes a headline isn't really the reality.
True.
And they I think hard work is glossed over. There was a ton of work that took getting to this place. And I kind of feel like anybody who is a one or a first has probably put in 10 times the work and the effort to get to that place. So
I believe that. Do you feel the pressure of being the first, being in this role? Is that not
for
really,
sure.
Yeah.
No,
okay.
It's real. That being said, I'm allowed to, or in this role, can influence the care for so many people in our community. And that's really what I want to be known for, is building kind of a sustainable, compassionate system that serves our community. It serves everyone. And so if I have to be a headline to get here, that's fine.
So be it.
Yeah.
So be it. I want to ask, I like the examples of when being a woman or being a person of color comes into the conversation. And I'll give a couple examples. There was, we did this event, Women on Boards, and she was the only woman on a board of the company that makes Candy Crush. And there was some idea of we should add a dating portion to Candy Crush. And she was like, listen, our core demographic of users, I think it was women in their 50s, 60s, married, they're tired, they're at home, ready to go to bed, just scrolling on Candy Crush. And she's like, this is not a good idea to add a dating portion. And then my personal example is we moved offices and there was no plan. This is a small company. There's no plan of unpacking the kitchen and where the paper clips go. And I told my CEO, I was like, you need to come up with a plan. I don't care who it is. If we take turns, if we assign, I don't know. I don't care. But if you don't do anything, I'm already seeing the women in this office starting to clean things up. I'm seeing the women put things away and it's not fair. And he was like, oh no, they don't have to do that. I'm like, no, I know they don't have to. But as a woman, I can feel it and see it. Does that make sense? So do you have an example of when your experience has come into a meeting or a decision based on being a woman or a person of color?
I would say probably the first time that happened would have been coming into my chief medical officer role and looking at labor and delivery and on OB. And it was really kind of partnership with our executive director of women's services at that time and saying, how can we change the outcomes for women of color? Because we were not immune to the same statistics as the rest of the organization. And I think it was, even pretty powerful to be able to call attention to it and then say, we need to actually come up with a plan to address this.
Is that how the Just Birth Network started, or was that before your time?
And no, it was kind of how it started. We were throwing darts at the wall, trying to think about what we could do. And the Just Birth Network is pretty amazing. It's developed into so much more. It's an amazing program that we have for kind of culturally connected support. So we have cultural navigators, childbirth educators, and the postpartum and the birth doulas, which I think made a significant difference.
And they were people of color, or they?
Yeah.
Yeah. Okay.
You get matched. So it statistically showed up in our C-section rate. So our C-section rate for women of color, first-time deliveries, low risk, were higher than our Caucasian rate.
Basically meaning like it was deemed more unnecessary. They were getting more unnecessary C-sections, kind of, right? Or
you don't necessarily know why, but you just know that the rate is higher.
Yeah,
and it may have been necessary, but how did we get to the point that it was necessary? So you don't really want to say it was unnecessary. You just know that the rate is higher and it should be lower. And so we started at 44.7% C-section rate, and we went down to 27% C-section rate, which is
I was reading it and I had to reread it twice because that is huge, especially as you said, this is not an issue that you at this hospital are dealing with. This is a nationwide issue. And to get it down to, I think it's pretty much even now, right?
Yeah.
Like almost the exact same amount between white and non-white. And that's so incredible. So is this going to be, you think it'll be shifted to other hospitals? We'll be able to do this program, or have people asked you about it? Not yet?
Yeah, no. People have asked us about it. We even had people come visit us federally to look at our program because our outcomes were so good. And the strange thing about it is it's not, you think it's a protocol or you think it's a pathway, when in reality, it's all about communication. So putting the doulas in the room, like bridged, the patient in the room had somebody that they trusted to give them clear communication. And so it was an intermediary between our medical staff and our clinicians and the patient, and it allowed them to communicate in a way that bridged barriers that we didn't even know we had that clearly exist all through healthcare. So it's this relatively simple for an amazing outcome.
Yeah. Speaks to the importance of doulas, too. I think sometimes they get dismissed.
For sure.
That they are very important. All right. Well, this has been really fun. I feel like I could talk to you about healthcare all day. But we are going to close out. And the last question, what's something you're not doing anymore? And this can be, it's supposed to be in a good way, but this can be silly, serious, personal, professional, but you're not doing it anymore.
No, okay. I'm done pretending I only need 5 hours of sleep. Because I think I need more.
Thank you so much for saying that. At the newspaper, we'd interview CEOs and we did like a day in the life, and they're all like, wake up at 4 a.m., go to the gym. I'm like, is that really what you're doing? But maybe.
No, I do. Oh. I wake up at 4:45 and I do my workout because, I'm older now, so you got to do strength training.
Yeah.
But I only do that 3 days a week.
Okay. So, but you're going to bed earlier probably is what you're saying.
Yes, I'm trying to go to bed early. I'm trying to get sleep because, sleep is necessary.
That's what the doctors say.
Yes.
Okay, so you're going to start sleeping more and stop sleeping less. I like it. Well, thank you so much for taking the time to sit down with me, and I really appreciate it.
All right, thank you. Thanks for having me. It was great.
All right. This has been The Weekly, with production assistance from Nick Patry. If you liked what you heard, rate us and write a review on Apple Podcast or Spotify. We love listener feedback, so if you have any story suggestions, comments, or complaints, email us at info@theweeklyseattle.com. Make sure to check back next Sunday for the latest local business news. We'll see you next time.